So good morning for the second day of this Hepatology update course. We are very happy to be in Bucharest. I had the pleasure to visit outside Bucharest yesterday, and I have to say what I have seen was fantastic. I will come to that. I would suggest to my co-chair Ferruccio Bonino to see Karol First Palace, summer residence. You saw it, yes. He's also very impressed, I'm sure. Now, the title of this session is What's New in Hepatitis? It's going to be we will be co-chair the session with Ferruccio Bonino. My name is Cihan Yurdaydin. Ferruccio Bonino is from Italy, I'm from Turkey. And the first talk is given by my co-chair Ferruccio Bonino from Pisa, Italy. The title is Emerging Issues in Hepatitis B, When to Stop Nucleosides, Renal Function, Risk of HCC, Quantitative Surface Antigen, Obstacle for Cure. Well, in 20 minutes, everything together.
Thank you. Thank you, Cihan. Thank you very much to the course director, Professors Georgi, Trifan, and Sporea. I'm very happy to be one more time in Bucharest, and I really share with Professor Yurdaydin the comments on the beautiful city, but also, I think, beautiful people in Romania. The job, excuse me. The emerging issues in hepatitis B, and particularly chronic hepatitis B, are many. Having 20 minutes talk, I will concentrate on few major one, that is nuc therapy, and particularly safety, risk of hepatocellular carcinoma remaining and after treatment, when and if to stop, and the role of quantification of surface antigen of hepatitis B virus in the management of these patients. The first safety concern is actually based on the kidney, since all the nucleotide analogs are secreted unchanged in the urine. So the renal function must be evaluated at baseline with creatinine clearance, estimated glomerular filtration rate in all the patients to define appropriate dose and dosing intervals. Potential nephrotoxicity is actually on tubular excretion, except from telbibudin, which can be a rescue drug to be used in people with renal problems. Another issue that is important for tenofovir is actually the bone safety. And in candidate to treatment, it is important to study the alteration of the bone metabolism with an accurate clinical history first, and if possible, with the appropriate test to measure the bone density at baseline and regularly during treatment. This is very important, particularly in HIV co-infected patients who are going to be treated with multiple drugs. Fortunately, today, finally, we have a prodrug of tenofovir that is consistently improving the safety, and not only safety, is also enhancing the availability of the drug at the liver level, and this is consistently ameliorating not only safety but also the treatment efficacy. And a few data can be seen in the slides showing how fewer are after this prodrug administration versus tenofovir, the decrease in bone density, and also how it is a glomerular filtrate estimate better. What it is relevant actually is that there is also an improvement in terms of lower ALT elevation with this administration of this drug, and no resistance, so the efficacy is similar. And what is relevant is that now in the guidelines it's really said and pointed out that indication for selecting TF of entecavir over tenofovir is related on age, on bone marrow, on bone disease situation, and renal alteration. So we can really have a very easy and simple guideline to avoid side effects, and also we can switch in those who are going to have side effect with tenofovir, for instance, to the prodrugs. And as you see from the slide, it is clearly evidence that you can improve both the side effects on the bone, and you see the hip and spine density after switching from tenofovir to the prodrug administration. So we have no major safety issues actually doing this type of treatment. So what we are trying to achieve with this treatment? First of all, we want to cure chronic hepatitis, clearing infection, or at least tapering and controlling infection. We cannot get rid of the infection so far, but we can stop inflammation. And stopping inflammation, we wish to cure chronic hepatitis B and eventually control it when it is already so advanced to have damaged the liver at the point of liver cirrhosis. On this issue, it is important to address a few points on what means the regression of fibrosis during treatment. These are some results showing the consistent improvement of fibrosis and regression of fibrosis after treatment, and the elimination of inflammation causes this dramatic change in the fibrotic staining of the liver, as you can see from baseline to week 240 in this single patient. What that means? That means that since inflammation is actually triggering the scaffolding of tissue remodeling and restoration. So it's like people coming to the site of destruction after earthquake and building a new city. And to do that, you need scaffolding. This is fibrosis scaffolding. This scaffolding goes away once we get rid of the inflammatory cells and we restore the condition. But how much of the scaffolding can be taken away? Probably not all scaffolding. This is interesting observation from famous Professor Desmet, one of the greatest hepatologists of the liver and pathological topic. He says and writes that essential components of cirrhosis are architectural distortions. So it's not fibrosis. It's actually vascular derangement, including intrahepatic portosystemic shunt. Once we have this vascular disruption, it's very difficult to think that we can remodel that to normality. Of course, we have never saw till now, till in the recent years, that we are able to cure a chronic disease like chronic viral hepatitis, that we will be facing maybe to see also such remodeling. In fact, properly, Professor Desmet says that it remains to the future, for the future to find out whether and in which extent we can remodel this major damage that occurs. This actually happens in the animal model, but unfortunately animal models are short-lived. There is not decades of disease, so it's completely different from humans. However, what I want to stress is that it is very relevant to define that cirrhosis is not only fibrosis, but is vascular derangement with major bridges between portal tract and the central vein. This alteration is the one that is more important for the risk of hepatocellular carcinoma. And in practical life, what can we do to monitor our treated patients? I think the best is to measure, for instance, liver stiffness. Liver stiffness is not a measure of fibrosis, of course. It's a measure of three components of this elasticity measure, that is congestion, inflammation, and fibrosis. Since it's very easy to get rid of the component of congestion in the condition of measurement, we know that in chronic hepatitis cases, we are measuring a combination of inflammation and fibrosis. So the number provided by FibroScan is the sum of these two vectors. It's very important to do monitoring. This was the original paper where we showed that in an acute case of hepatitis, we have very high FibroScan value because of high inflammation that goes completely away in a few weeks and jumps up when there are relapses. So liver stiffness is important to be a monitoring tool in treated patients, because if it does not go down quickly, and particularly if it starts from very high value, it means that one component of that value is probably the distortion of the liver at the level of a real vascular alteration, that is cirrhosis. So this is important, because the big question is how important is the impact of treatment on the rates of hepatocellular carcinoma, that we know that untreated patients, as you see in this large work in Asia, where NUC-treated patients have a hepatocellular carcinoma rates consistently and significantly lower than untreated. And in Europe, you have a study where we compared in a multi-center study the rate in cirrhosis and non-cirrhotic after treatment. And you see that makes a lot of difference when we start therapy. When we start therapy and already the distortion of the architecture of the liver has reached that level that we talk about, we have a higher risk of hepatocellular carcinoma than when we can clear completely the fibrosis due to regeneration and not to vascular alteration. This is another study just showing elegantly the expected rate of cancer in black holes versus expected is, dot line, and the holes were the events. And actually, it is really shown that in cirrhotics, we can have not major advantage versus the expected line, while we have a consistent advantage in non-cirrhotics. So the real issue is to treat as early as possible patients with chronic hepatitis. Nevertheless, even when cirrhosis is reached, we can still impact. The issue is when we have a patient in long-term treatment, can we stop it? It is known that we can stop therapy, and there are maintenance of control of viral infection. So guidelines already foresee the discontinuation, particularly in E-positive patients, once a stable HBIG to anti-HBe seroconversion has been achieved and undetectable HBV DNA has been consolidated. But discontinuation can also be performed in anti-positive, E-negative chronic hepatitis B, where it's more usually consistent long history and the risk of cirrhosis or, more important, liver damage. Of course, the selection of patients has to be based on single case criteria, and so the possibility to make a choice just on reliable predictor are not so far well defined. Nucleoside analog discontinuation results frequently in a virological rebound that in most of the time is self-limited and leads to the complete restoration and consolidation of treatment with maintenance of control of HBV infection. However, reactivation can lead also to biochemical and histological rebound of hepatitis that can be severe and can be at risk in patients with underlying advanced liver disease. So the major issue is how long we have to monitor eventually in patients where we decided to stop treatment. Of course, the decision is a participative decision. It should be consensus based on the patient's request. And once we do that, we have to be very careful to monitor continuously and precisely patients after discontinuation, because the lag time between discontinuation and relapse is different. According to different reports, it appears to be a little longer or with a wider range of relapse rates in Asian patients. Probably this is because of many factors. Of course, one important reasonable factor can be the duration of the nucleoside analog treatment. That means a strong consolidation of a suppression of viral replication. From the Asian studies, it appears that type C genotype of HBV has a higher risk of lag phase, longer lag phase compared to type B. type of nucleoside analogs. There are preliminary data showing that entecavir may be having a longer lag than tenofovir. And of course, we have to monitor some biochemical marker. And since monitoring HPV DNA, we are already monitoring the event, because RLS means increase of HPV DNA. We need an alternative marker, not the marker of the event. The only alternative marker that can give, so far demonstrated in a larger number of studies, some significance are the levels of HBsAg during the treatment and the lag phase. This is just a study showing that probably entecavir is providing a suppression that is a little more consistent than that of tenofovir. In fact, it takes longer to reactivate. These are quite consistent data. It's not surprising. It's more potent inhibitor even in Bucharest models. So this can be really hypothesized. What is about the transaminase and biochemical flare-up that occurs after reactivation of viral replication? Is it bad or good? This is a question that looks like a Shakespearean question. The definition of bad, unfortunately, can only be after. So we can never be predictive of how bad it could be, only on criteria that we can pose after. Before, we can reasonably think that it is better not to stop in advanced cases of liver damage. So it's the logic of the clinical hepatologist to understand when it is possible to think about stopping treatment or not. We are also I am an old hepatologist. I remember the old time when we have only one drug, corticosteroid. And we were using corticosteroid boosting to induce a flare that was sometime switching E positive to anti-E positive chronic hepatitis B, just because of triggering replication and necrosis. This is published. Those were so-called good flare-up in E positive patients at that time. But of course, in early cases of chronic hepatitis B, not in patients with advanced liver disease. So the hepatology is always the same way of looking with a clinically minded, thoughtful way of managing. Hypothetically, we can start to distinguish from the dynamics of the markers. Of course, if we have a case with consistent decline of surface antigen level, even if we have a flare, and that levels is even precipitating or clearly significantly going down during the flare, this is good news. Instead, if we have a flare, but instead of going down, even stay stable or may increase the level of surface antigen, this is indirect evidence that probably that flare is not going to be resolutive to induce a stable control of the infection afterward, then probably we need retreatment. And so the retreatment may be based also on these levels that Maurizio defined a few years ago in a consistent study, because definition of cutoff is important, but you have to be consistent. This study was based on 24 months of monthly testing of a large cohort. And this works particularly well in genotype D, because the levels are genotype dependent. So this is important. But in Romania, you have genotype B prevalent. This was so solid that even in the cohort of Taiwanese people, the large cohort famous of Taiwan that I followed for years, the levels of 1,000 is the only marker so far predicting cancer. So this is clearly published in gastroenterology in 2012. So the levels of surface antigen below 1,000 is an indirect, is a general population cutoff, but is useful to define also the risk of hepatocellular carcinoma in terms of consistent evidence-based data. The role of quantitation can even be improved. Of course, the lower it goes, the better. This study shows that prediction of sustained response is even stronger and consolidated if it is lower. Of course, if it becomes negative, it is very good that it is negative. So the decline of the markers of seroconversion means that we are going to achieve it, of course. So the guidelines say that nucleoside analog can be discontinued, but only in patients who can be followed closely, and I would add consistently with a participative, informed consensus achieved decision with the patient. That's very important. Retreatment criteria have to be based on the same criteria for treatment, and this is logical. But the so defined criteria to make this decision will never be at the single patient-based level, of course. So there is a consistent and finishing job anyway, not only on the monitoring, but also, of course, so on treatment. We have not the so beautiful landscape of hepatitis C. So there is huge need to improve. I am not the topic to discuss on this, and I will thank you very much.
Thank you, Dr. Ferruccio Bonino, for the nice talk. Questions from the floor? Can I ask one question?
Yeah.
In terms of nucleoside analog discontinuation, it started with adefovir discontinuation, which was followed by surface antigen clearance, but it appears that surface antigen clearance depends on the genotype you have. And with genotype D, what should we look for in terms of on long term if surface antigen clearance is not achieved? Is it that we look at the conversion to a so-called inactive carrier state? What would you think?
Of course, the first goal is to achieve the control in a level that there is no inflammation, and so we maintain the patient in a condition similar to the previously called non-active carrier state. If we are willing to achieve the seroconversion to anti-HBs, that is an issue that I agree is not easy to achieve in anyone, and depends how much surface antigen is produced by integrated virus. And so far we have no test that so precisely tells which the production of circulating surface antigen. Definitely I think monitoring dynamics over time of surface antigen can be helpful. The dynamics are not identical in every patient. They are not continuous. There may be moments where we see a strong, quick decline. Once that happens, usually it goes to the seroconversion. Another issue, if the patient wish to stop the treatment, we can even discuss whether to have a short course of interferon speeding up the clearance at the time, and then stopping therapy using a short course of interferon that increases the decline of surface antigen, surely better than nucleoside analog, because interferon is inhibiting surface antigen also. So we have many options. They are not standardized options. They should be performed under studies and under consensus of the patient, because the patient is taking a pill that is maintaining anyway with no disease the liver, and the risk of reactivation in somebody who can have troubles out of this eventual relapse should be considered carefully with the consensus of the patient. So this is the point.
Okay, thank you. Any other question? Yes, please.
Advanced fibrosis, as it is defined now, would you think twice?
Well, I think you are right, and I think FibroScan can help. If the FibroScan does not go down, for instance, you still maintain 8 to 12 or even higher value of elastometry, that means that you have, of course, because you have clear inflammation. If fibrosis stay up, now we know that that is fibrosis. FibroScan is not measuring fibrosis, but is measuring the index that is sum of the two. So you can either, but we can even liver biopsy. So we have forgotten liver biopsy. We in the old times, we with white hair did a lot of biopsy, and we have learned to treat properly with biopsy. So in some cases, at most, we can even biopsy. Of course, there are cases where you have doubts of what you are going. But nowadays, I would say, if you have, in a good elastometric context, a value that fits with higher, I agree with you, that means fibrosis. So that can be a case where you consider not to stop.
Okay, thank you, Dr. Bonino. Should I announce?
Now we have Professor Gian Gilardin giving us the presentation on new therapeutic strategy against hepatitis delta infection and disease.
So again, good morning. I want to start with thanking the course directors, Professor Diana Georgia, Ioan Sporea, and Anka Trifan for their kind invitation to come to Bucharest once again. So my task is to talk on new therapeutic strategies against hepatitis D. And I think I have to do this. Yes. The last one. So, let's start with facts. Chronic delta hepatitis, we all know, is the most severe form of viral hepatitis. It is a disease of the developing or underdeveloped countries or regions. It has received orphan disease designation in the European Union and the USA. And so far, the only therapy of proven benefit is with interferons, but results are suboptimal. Biomedical industry displays little interest for new drug development so far. They see it as not cost-effective, probably. And so academia may come to rescue, and this is what we seek nowadays. Liver injury in delta hepatitis is immune-mediated. And concerning the latter, I just want to draw your attention. I'm not going to discuss these two papers, which are impressing gastroenterology. One is from Germany, the other is from the NIH in the US, which suggests that mutations in the HDV RNA sequence, in the HDV RNA genome, polymorphism here leads to mutated peptides, which most likely leads to escape detection by CD8 T cells and may be involved in the pathogenesis of liver injury in delta hepatitis. Delta hepatitis is a co-infection, and you have to remember hepatitis B delta. And what we are facing is delta hepatitis is mostly the disease of the dominant virus, and this is delta D virus. And indirectly, this has been shown by immunohistochemical studies where core antigen was localized in a nuclear position, which does not correlate with liver injury as is seen in hepatitis B as well. Core antigen in the cytoplasm correlates with liver injury, but not nuclear. Delta antigen, there is a correlation with ALT. Not very significant, not at a high level, but still there is a correlation. Now, in terms of to give some update on delta hepatitis for a short minute, I want to mention this epidemiology studies. The global overall HDV prevalence is estimated to be 5% of the hepatitis B population. This is the World Health Organization estimation. Now, there was a recent paper, which is still not published, but it's in Press in Gut, which with the title Prevalence and Burden of Hepatitis D in the Global Population, a systemic review and meta-analysis. So this was, they searched for 182 articles from 61 countries, and they came up with an HDV prevalence on a global scale of 0.98, so 1% of the world population, according to this study, is infected with delta. And seroprevalence was 10.58% for so 10.58% for hepatitis B. But there was a criticism, and this appeared as a letter to the editor, and basically, again, 1% of the population of the world populations appear to be is supposed to be infected with Delta, and 10.58% of surface antigen carriers. And remember, this is without IV drug users and high-risk sexual behavior. So if you think that the world population is 7.5 billion, 1% would mean 75 million Delta virus infected persons. And this would, if this is 10.58% of HPV carriers, 100% of HPV carriers would be 708 million people with HPV. This would be more than 3 times, or approximately 3 times the estimate of the current estimate of hepatitis B prevalence around the globe. So you have to think, I mean, this paper suggests that the 5% HPV population of, that 5% of HPV population is infected with HPV is an underestimation, but more likely their study is an overestimation. And I just want to quote, I have this from, I have to say, from Peter Ferenczi, I don't know if he has it from anyone else, Paul Descartes, a mathematician, a philosopher, who said, what is the wording? Real numbers, let's see, good numbers. Good numbers, like good people, are very rare. So you have to be very careful in estimation of prevalence studies. I want to skip those. Basically, in the Western world, as well as in the Asian Pacific, Delta is more seen, not in the general HPV population, but in IV drug users, in high-risk groups. Now, in terms of treatment, what we have, I just want to mention the 2 key studies, the HEDIT-1 and HEDIT-2 studies in Delta hepatitis, which were the largest studies ever done in Delta hepatitis, the 2 largest studies. And there appears to be 28% of viral response after treatment stopping. It was interesting, it was disappointing to see that 2 years of treatment in the HEDIT-2 study led to quite high relapse rates, and the overall post-treatment month 6 treatment response, viral response, was not different than the 1-year treatment. But once you have a response, first of all, in this slide you can see on the left that the red color, the red line is for interferon treatment, and the blue line is for no therapy, green is for nucleoside analog therapy. This is based on the cohort of the Hanover group, and it shows that interferon-treated patients have a better cumulative event-free survival. And we, at our cohort, showed that it is the group of patients who have a maintained virologic response, which we defined as post-treatment 2 years of HDVR negativity, had a better event-free survival. So once interferon works, it is effective. But what is the optimal dose and duration? We know the dose, it's the high dose, but in terms of optimal duration, based on our cohort, we have shown that the longer to treat, the better the response. Of course, this is a retrospective cohort study. There is some bias in it because it is likely that patients who do respond somehow are more likely to enter into the longer treatment periods. But it is also it is also linked to in vitro studies which suggest that interferon treatment in Delta hepatitis is actually not very effective. So there were several studies in vitro which suggest lack of efficacy of interferon for Delta virus. But basically it came out that interferon inhibits at an early step of infection at the level of hepatocyte entry. And this has been shown also recently by the group of Stefan Urban. What means entry step is an early step, but you have to think that you prevent entry of the virus to other hepatocytes, which is a long process. And if you look to kinetic studies with interferon in delta hepatitis, you see that at the beginning, there is a first phase fast decline of HDV RNA. Then there is a more or less plateau or slower decline. But even the first rate decline lasts long to appear. So long delay before PEG interferon affects HDV RNA has been shown. Median 8.5 days. You have to compare it with data in HBV or HCV where the duration of starting of efficacy is 8 to 10 hours, not 8 to 10 days. So basically, it appears that delta hepatitis is not the virus which responds to interferon very favorably. Now, the importance of new treatment is shown in studies in the HIV population, which suggests that we are left with delta hepatitis as a trigger of mortality in this HIV population. We have very good antiretroviral treatment. We have treatment for hepatitis B, and now also for hepatitis C. This paper is from 2014. It does not reflect the effect of direct-acting antivirals on the HIV-HCV population. Still, so the blue color, which you see, which is the hepatitis C population, will move upwards. So in the current state, it is basically delta hepatitis which leads to mortality. And this is again shown in another very nice study from Switzerland, where overall survival on antiretroviral treatment, if you compare HDV RNA positive versus negative patients, HDV RNA positive patients have less survival, overall survival, HC-free survival, and liver-related death. Delta hepatitis is a rare disease, but it accounts for significant morbidity and mortality, and therefore it is very important. New treatment approaches. I just want to mention that delta hepatitis does not have persons like Freddie Mercury or other very important known figures with this disease. Therefore, it is important that we raise awareness and we simplify the way to acceptance of new treatments by the state agencies. Therefore, a group of experts came together and suggested as surrogate of initial treatment efficacy for delta hepatitis, an end of treatment 2-log decline compared to baseline. This is of course not reflecting that this surrogate is a surrogate for long-term efficacy, but it shows that yes, we have a treatment which shows some efficacy and you have to work on it. Now, what are the new treatments? We have the entry inhibitor, Mircodex-B. We have the virion assembly inhibitor, lonafarnib, the farnesyl transferase inhibitor. We have nucleoside analog polymers, and we have PEG interferon lambda. These are the main 4 treatment approach in phase 2 studies currently. Characteristic of these novel treatments, if we left outside PEG interferon lambda, so Mircodex-B, they all are in phase 2 studies, and lonafarnib and Mircodex will start, in the process of starting phase 3 studies. Their mode of action is shown on the slide, but importantly, Mircodex is given daily as subcutaneous injections, lonafarnib is given orally, the nucleic acid polymer Replicor Rep 2139 is given as an IV infusion. So let's start with Mircodex. The first study was published in Journal of Hepatology 2016. I'm not going to discuss the detail, but what appeared in this first study was that Mircodex had a modest efficacy, but when combined with PEG interferon, there appeared to be a synergistic effect. Then the phase 2 study, which was presented at EASL and at the last ASLD, compared tenofovir pre-treated patients with, first of all, several doses of Mircodex were compared, and for a duration of 6 months, and they have shown that there is not much difference between the efficacy of 2 and 5 milligrams of Mircodex. 10 milligrams appear to be a little bit more effective in terms of HDV RNA decline, 2 log decline or HDV negativization at week 24. And this was accompanied by ALT normalization, but the higher dose was not as good as the viral load decline. But then came the multi-center open-label phase 2 clinical study where safety and efficacy of Mircodex in combination with PEG interferon was assessed. So this is the treatment schedule. Treatment was for 48 weeks, and 2 doses were with PEG interferon, and this was compared to PEG interferon monotherapy and Mircodex monotherapy for 48 weeks. First of all, since it competes with bile salts, NTCPs also is a bile salt transporter, and Mircodex blocks bile salt transportation, should block it, and this was the case, but this was not associated with any adverse effects. Virologic response shown here. The green and dark green colors are the combination treatment Mircodex plus PEG interferon. As you can see, in terms of viral efficacy, they appear to be much better compared to PEG interferon monotherapy or Mircodex monotherapy. Again, shown on the right is the log decline delta decline in terms of at week 48 compared to baseline, and again, a potential consideration of synergistic efficacy should be considered. Now, virologic response in terms of undetectable HDV RNA at week 48, altogether 15 out of 30 patients with combination treatment had undetectable HDV RNA at week 48 at end of treatment, and this is much better compared to the 2 out of 15 patients who had an end of treatment viral response with Mircodex or PEG interferon monotherapy. But more importantly, what is interesting was the surface antigen response. The number of patients who had more than 1 log decline at end of treatment was 0 with PEG interferon monotherapy and with Mircodex monotherapy, but 9 out of 30 patients with combination treatment had this more than 1 log decline of surface antigen response. And based on this favorable response, a phase 2 study in hepatitis B monotherapy is also in the planning. So in summary, Mircodex was safe and well tolerated, and Mircodex in combination with interferon in combination with PEG interferon was very effective, undetectable HDV RNA in 50%, and altogether around 1/3 of patients with combination therapy had a more than 1 log decline of surface antigen. Now, prenylation inhibitor lonafarnib. The first dose-finding study was published in Hepatology last year, and this study suggested that compared to monotherapy with lonafarnib, combination with PEG interferon or combination with ritonavir appeared to be combining best efficacy with safety. Another finding was that in some patients, Ferruccio Bonino mentioned the beneficial flares in hepatitis B. That appeared also in delta hepatitis, where at end of treatment there was a biochemical and viral flare, which then subsequently ended up with ALT normalization and undetectable HDV RNA. Now that can be combined with some in vitro data where the Stefan Urban group looked at the mechanism of action of Mircodex-B and lonafanib. With regard to lonafanib, one concern is that you block basically virion assembly, and you block extrusion of new virions outside the hepatocyte. What happens then? Could that be toxic to the cell? And that accumulation of surface antigen within the cell has been shown here. I don't have, can I see it? Well, I'm not sure. So you see the lonafanib title, and you see the fluorescence with a heavy fluorescence with lonafanib. So there is an accumulation, but cellular toxicity studies showed that there was no cellular toxicity. This is important. The other thing which is important is they also looked at induction of innate immunity. And as you can see, Mircodex-B was not associated with an induction of innate immunity, but lonafanib and interferon alpha was. So that might explain why we see these beneficial flares at end of treatment and after treatment. And lonafanib may have a dual mode of action. One is virion assembly inhibition, and second, immunomodulator efficacy. And as reinfection of hepatocytes has been shown both for Mircodex and lonafanib. With interferon, there is also prevention of reinfection, but this is more modest compared to the first two drugs I mentioned. The lower two dosing study was aimed to find dose optimization, and high doses of lonafanib were compared with low doses, now always in combination with ritonavir, with or without pegylated interferon treatment. And what appeared was that the high dose, first of all, did not lead to better antiviral efficacy. And second, the high dose was associated with grade 2 or 3 toxicity, according to CT's, the common terminology of adverse event criteria, where almost 50% of patients had grade 2 or 3 toxicity. With the low dose group, this CTCA toxicity of grade 2 or 3 was less than 15% of cases. So low dose combination was better tolerated and showed better efficacy. Now, the other thing what appeared was, first of all, lonafanib, the low dose 50 milligrams BID with ritonavir compared to lonafanib 25 milligram with ritonavir. The 50 milligram dose showed a better antiviral efficacy at end of treatment through week 24. Now, but combination of with pegylated interferon appeared to be much more effective again. The blue line is lonafanib monotherapy, 25 milligrams, and the yellow line is triple therapy with 25 lonafanib, and you can see there is a synergistic, there appears to be a synergistic efficacy. And the same holds true for 50 all oral and triple therapy with PEG interferon. So in summary, all oral lonafanib boosted with ritonavir was associated with 33% patients had a more than 2 log decline at the end of treatment, week 24. 47% normalized ALT, but combination with PEG interferon appeared to be the most effective. 78% of patients had a 2 log decline and 88% normalized ALT. What about PEG interferon lambda? Is a better tolerated interferon. That's the general impression. The reason for that is it binds to a unique receptor, and which is highly expressed on hepatocytes, but there is limited expression on other cells in the body, including hematopoietic cells, and therefore the side effect profile is less with interferon lambda compared to interferon alpha. What about efficacy in hepatitis B and hepatitis C? There were 2 studies, and they show more or less similar efficacy. What about the phase 2 study in delta hepatitis? This was performed in, it was a multi-center study in New Zealand, Pakistan, in Israel. 2 doses of peg interferon lambda was compared, 120 microgram and 180 microgram for 48 weeks, and there was 24 weeks of follow-up. The results of the 48 weeks showed that the higher dose was more efficacious, and the results of post-treatment week 24 will be presented as a late breaker in the next week at the EASL meeting. I just can tell you the figure which was announced, that more than 30% had a post-treatment week 24 response at post-treatment week 24. Now, what about nucleic acid polymers? These are interesting drugs. They appear to be very effective. Their mechanism of action is not entirely understood, but so far the only study performed in delta hepatitis is a phase 2 study in 12 patients performed in Moldova. They were treated with Replicor 2139 as an intravenous infusion for 15 weeks. Then they received combination of Replicor with pegylated interferon. And then for the last 18 weeks, they received interferon monotherapy, and they had follow-up. Their follow-up is up to 3 years. And what you can see is, forget about delta hepatitis. If that's true, it could be a asked treatment for hepatitis B as well, because there is a striking decrease not only in HDV RNA levels on the right, but also there is a striking decrease in surface antigen levels. And 1.5 years after treatment stopping, HDV RNA was negative in 7 out of 12 patients, and surface antigen was negative with high levels of surface antibody titers in 5 out of 12 patients. So these data need to be confirmed in larger studies. Now, registration studies, phase 2-3 studies are starting for Microlix-B and lonafarnib. Nucleic acid polymers, they are looking for subcutaneous formula adaptation, followed by small pilot study, to be then followed by registration study. That's their aim. So in summary and conclusion, the only effective treatment for delta hepatitis is still with interferons. Treatment beyond 1 year is needed in a sizable proportion of patients. New drugs are an urgent need. Good results with the 3 drugs I mentioned, and also with interferon lambda. The important thing is that pegylated interferon may still be used as backbone for some time. We expect to enter a new era in the management of delta hepatitis, and this is my thank you in Romanian. Mulțumesc. Thank you.
Thank you, Gian, for this very nice and extended, comprehensive review of the problem. There are questions in the audience? If not, I have a question myself. It is a long history based also on the biology of the 2 viruses that clearly hepatitis delta cannot build an infection and a disease in any carrier of hepatitis B virus. You need somehow a replication machinery. On the other hand, you cannot infect only 10%. Delta is so infectious that can be able to infect in the chimp experiment till to a dilution of 10 to the 12. But it needs some replication of B virus. So the vision that is being published by a paper of us in hepatology and gastroenterology 33 years ago was saying that we need some replication of hepatitis B. So couldn't be that the reason of the good flares that happens and interferon response and also Mircludex is targeting actually a way to block completely replication and expression of the full machinery and secretion of the complete envelope of hepatitis B virus. A completely different strategy is to hit prenylation and other specific mechanism of hepatitis delta. So there is a kind of quite divergent strategy. The first one, Mircludex, peginterferon, is actually aiming to block also hepatitis B replication in those subsets where only delta can grow. What do you think about this?
Well, I mean, in the studies with lonafarnib, where we saw these flares, these are data from Ankara, and in these patients, none of them had received previous or concomitant nucleoside analog therapy. And what we saw was those patients who had a flare had during treatment a rise in HBV DNA. So delta was decreasing, HB was coming up. But this rise in HBV DNA was not associated with a rise of ALT. And in one patient whose flare was very severe, except this patient, in the other patients, hepatitis B virus DNA came back to undetectable levels or to baseline levels by its own without receiving nucleoside analog therapy. So the contribution of hepatitis B in this scenario is difficult to assess, but it looks like that lonafarnib led to a state of the immune system which was similar to reactivation of hepatitis, whatever the cause, in the acute setting or in the chronic setting with active reactivation. And this immune reactivation, also the arousal of the immune system, may contribute to the cessation of disease.
Thank you. Thank you very much. We move to the next presentation. Thank you. That is from Professor Oksana Shirley on hepatitis E, an emerging issue. Thank you.
Good morning, ladies and gentlemen. Thank you, Professor Gheorghe, Professor Trifan, for inviting me to present this topic. Why is hepatitis E an emerging issue? Of course, the first reason, because of significant morbidity and mortality in the Western countries, because previously it was thought that this hepatitis E virus was limited only in Asia, in Africa, and in the Western world we had infections only from patients with, who had traveled in this endemic area. But nowadays, locally acquired hepatitis E virus is the main cause of acute viral hepatitis. Also, we must know that hepatitis E virus is a zoonotic infection. So in some genotypes, not the human is the main host, but one of the main hosts is the pig. And the way of infection is including by consuming infected meat. So these are the reasons for which in 2018, the EASL clinical practice guidelines were published regarding hepatitis E virus infection, and my presentation is based mostly on these guidelines. So who or what is this virus? It is an RNA virus from Hepaviridae family that infects mammals, birds, and fish. You see here genus Orthohepavirus, species A. But the most important thing that there are 8 genotypes who are not different only regarding their phylogenetics, but also regarding their clinical manifestation. And you see here genotype 1 and 2 infects mostly humans, and they are endemic in some areas, in Africa, both of them, in Asia, genotype 1, and also in Mexico, genotype 2. So these genotypes infect mostly humans. Genotype 3 and 4 are distributed worldwide, and they infect animals and also humans. And the most frequently infected animals are pigs, also deer, also boars, and genotype 7 was identified in camels and also with possibility infection in men. I told you before that there are some differences regarding the genotypes. Genotype 1 and 2, they are mostly found in Asia. You see a high number of infections worldwide already due to their spread in the world. But they are responsible of over 70,000 deaths per year. And these are older data from 2005. But probably now the number of persons infected by this genotype is higher. Usually it is a brief, self-limiting infection, usually in young adults, and the way of transmission is mostly fecal oral. They are never chronic, but there is a problem with patients who already have a chronic liver disease or cirrhosis, in which an acute infection may be life-threatening, with mortality rates as high as 67% in some studies. Also, a very important fact is that in pregnant women can lead to a very severe disease with a mortality of up to 25% due to fulminant liver failure, eclampsia, hemorrhage, but also with very negative effects on the newborn with a lot of prematurity and negative consequences for the fetus. So the easy recommendations are that travelers with hepatitis returning from areas endemic for hepatitis of HEV virus should be tested for the infection. And also if HEV infection is identified in pregnant women, they should be cared for in high dependency setting and also transferred to liver transplant unit if liver failure occurs. Regarding genotype 3 and 4 in epidemiology in Europe, it is endemic in developing countries, but now it is the most common cause of acute viral hepatitis in many European countries. And you see here there are some areas in which the infection is more frequent. In Italy and in Poland, you see a seroprevalence of almost 50%. Also, studies demonstrated a high level of a high proportion of contamination of the blood donors. You see 1 in 600 donors viremic in the Netherlands. Thus, a high potential for further infections. How is genotype 3 and how are genotype 3 and 4 transmitted? I told you it is a zoonotic infections. They are very contagious in pigs, in wild boars and deers. It is considered that if a pig in a herd is infected with hepatitis E virus, all the pig in the herd will become infected. The infection is asymptomatic in pigs, but the virus is excreted through the stools. And if the dejections are not well processed, it can infect the water. So way of transmission to the human is first by consumption of infected undercooked or uncooked pig meat, but also the consumption of shellfish from water contaminated with pig dejections, also with fruits and vegetables which are irrigated with contaminated water. And of course, if the patient is viremic and the blood is not tested, and the blood is given through transfusion to another individual, another way of transmission. Which are the clinical manifestations in acute infection when a genotype 3 HEV? In most cases, the infection is silent. The patient presents only with increased liver function test, but also the patient can have jaundice, fatigue, itching, nausea. Immunocompetent patients clear the infection without any intervention. Some rare cases go to acute liver failure, and this is very important in patients who already have chronic hepatitis of cirrhosis, in which the infection can lead even to the death of the patient. After the infection, non-sterilizing immunity develops, and reinfection is possible, but with lower risk of symptomatic hepatitis. So the EASL recommendation are that all patients with symptoms consistent with acute hepatitis should be tested for HEV, and also EASL suggests testing for hepatitis E in patients with unexplained flares of liver function test if the patient already has a chronic liver disease. Regarding chronic infection, is chronic infection possible? Yes, in immunosuppressed patients, and we define chronic infection as HEV replication for more than 3 months. Which are the patients who are most at risk? Those with solid organ transplant in their history, in which more than 50% will develop chronic hepatitis. Among these, 10% can either progress, rapidly progress to cirrhosis, to liver failure, and are in need for liver transplantation. Also, patients with hematological disorders, individuals living with HIV, and patients with rheumatic disorders receiving heavy immunosuppression. Most patients are asymptomatic, and only mild and persistent liver function test abnormalities are found. So the EASL recommends that HEV should be tested for in all immunosuppressed patients with unexplained abnormal liver function tests. Regarding the extrahepatic manifestation, the most frequently encountered are those neurologic. And among these, Guillain-Barré syndrome, neuralgic amyotrophy, meningoencephalitis. Also, renal and hematologic manifestation can be found, especially in immunocompromised patients. And the renal impairment can manifest by proteinuria caused by glomerulonephritis or IgA nephropathy. Regarding the hematological manifestation, thrombocytopenia, cryoglobulinemia. So that EASL recommends tests for HEV irrespective of liver function test in patients with neurologic amyotrophy, in patients with Guillain-Barré syndrome, and also it is suggested in patients with encephalitis or myelitis. Once HEV infection is proved, it is suggested to test for proteinuria, especially in immunocompromised patients, and also if a patient with HEV infection develops proteinuria, it is suggested to perform liver biopsy. How can we diagnose HEV infection? Of course, by biological test. The incubation period in HEV infections is up to 60 days. About 3 weeks after infection, HEV RNA can be detectable in blood and also in stool. The biochemical markers are elevated at clinical onset, so approximately 3 to 4 weeks after the infection. And the first that appear are IgM followed by IgG antibodies against HEV. So the laboratory diagnosis relies on serological testing upon detection of IgM and IgG. Also, viremia can be found in blood and in stool, and is indicative of HEV infection. In immunosuppressed patients, we can only rely on detection of the viral load, because in some cases the antibodies cannot be present. Also, in chronic cases, we must search for the viral load to evaluate patient response to treatment and to the identified relapsing infections. HEV antigen persists several weeks after the virus is cleared from the blood. Which are the most important differential diagnosis problems? First of all, in acute hepatitis, all causes that can lead to acute hepatitis. In the adult drug-induced liver disease and autoimmune hepatitis, both diseases that can present with very high aminotransferases, but of course other hepatitis viruses. In chronic HEV hepatitis in immunocompromised patients, first of all, we must think of graft rejection, of course, of drug-induced liver injury, of recurrence of primary liver pathology in liver transplant patients, in graft versus host disease, and other intercurrent infections, sepsis, but also with other viruses like Epstein-Barr or cytomegalovirus. So the EASL recommendations are that all patients with hepatitis should be tested for HEV as part of the first-line virological investigation, irrespective of travel history, and patients presenting with suspected drug-induced liver disease should also be tested for HEV. What about HEV and the blood supply? Of course, we must avoid at all costs to infect the patient through blood supply. But if the blood isn't tested, you cannot find the infection. And you see here some studies that were performed in which the viral load was searched for in blood donors. And you see a very high prevalence in the Netherlands, 1 in 60 blood donors, and much lower prevalence in Australia and Canada. So the EASL recommend that patients with abnormal liver function tests after receiving blood products should be tested for HEV, and also, if possible, depending on the financial resources and on the epidemiology of HEV in the respective area, to test all the blood for the viral load of HEV. What is the treatment of HEV? Acute hepatitis E virus infection usually does not require antiviral therapy because most of the cases are cleared spontaneously. But some patients may progress to liver failure, and it was proved that early therapy with ribavirin may shorten the course of disease and reduce overall morbidity. So the EASL recommended that ribavirin treatment may be considered in cases of severe acute hepatitis E, especially if acute hepatitis E occurs in patients who already had chronic liver disease. Regarding the chronic infections in patients who had a solid organ transplantation, the first step is to decrease immunosuppression if possible. That can lead all by itself to viral clearance. In patients in which the replication of HEV continues, even if immunosuppression is reduced, ribavirin treatment for 12 weeks should be considered, and after the course of 12 weeks, we must search for viral replication in blood and stool, and if both are negative, ribavirin treatment should be stopped. But what about the patients who do not respond to a 12-week course of treatment? The treatment should be extended for additional 3 months. But the optimal therapeutic approach is still unknown and still is a subject for research. But in patients who received a liver transplant and who are still viremic after 6 months of treatment, we can consider pegylated interferon treatment. How can we prevent HEV infection? Of course, this is most important in patients who already had chronic liver disease or are immunosuppressed. They should be advised to avoid consumption of undercooked meat, especially from pigs, boar, and deer. Also, we try to avoid the risk of patient-to-patient transmission, which is poorly defined, but still there are some data regarding the sexual transmission possible in men having sex with men. Also, considering that the viral load in the stool is very high, strict hygiene should be applied to patients who are infected. And regarding the vaccine, there was a vaccine who was developed, but which is approved for use only in China. Also, the ISL recommends that immunocompromised individuals and those with chronic liver disease should avoid consumption of undercooked meat, and especially from pork. And also, immunocompromised patients should consume meat only if it had been thoroughly cooked at more than 70 degrees Celsius. The conclusion of my talk is that HIV infection is more frequent than we think. We should search for HIV infection in acute hepatitis in immunocompromised individuals with unexplained elevated liver function test. Usually it is a self-limited infection, but beware in pregnant women, in cirrhotics and immunocompromised, in which can lead to a severe liver failure, and consider treatment in severe forms of acute hepatitis and chronic infection. Thank you.
Thank you very much for the beautiful presentation. There are questions? Just some comments, and actually in the guidelines it said that we need to have the travel history. Actually it's not travel, is eating what has been the food in the last days, because it's not necessary to go to China to have the uncooked pork. Maybe you have it also in Bucharest in the Chinese restaurant.
We also have it in Timișoara, where we like to eat sausages which are preserved only by smoke, and we find it more and more frequently if we search for it.
And another issue is, since we are going to personalize stepwise everything in medicine, healthcare, it appears clearly that, for instance, in immunosuppressed or going to be immunosuppressed patients, like for instance, patient going to transplant, blood used for transplanted people maybe should have a special care with more sophisticated PCR detection. What do you think for an extra measure? Because instead of generalizing the screening of something that will not be so much difference for a normal person, we should maybe make a special issue in the blood that goes to the transplant unit or to the building for transplantation or immunosuppression patients.
I think this is very important, especially in areas with not insufficient funding, where the search for all the blood for the viral load of HIV is expensive. But I think really that in a special situation, it should be a case-by-case approach.
Thank you.
Thank you.
Now we're coming to the last speaker of the session, who will talk on sarcoidosis of the liver. And this is Vico Cincinnati from Münster, Germany. Okay, Dr. Vico. Vito.
Dear Chairman, dear colleagues, first of all, I would like to thank the organizers, and especially Diana, for inviting me here to come to Bucharest to attend the 6th Hepatology UpDate course, and it's always a pleasure for me to come to Bucharest. First, I would like to give you some facts about sarcoidosis. Sarcoidosis is a chronic inflammatory disease of unknown etiology. And non-caseating lung granulomas are present in more than 90% of patients. Extrapulmonary disease contributes to a significant morbidity, but can be easily missed as a cause of sarcoidosis. And the prevalence of extra pulmonary manifestations is highest among Afro-Americans compared to Caucasians. And remission occurs, spontaneous remission occurs in up to 65% in patients after 1 to 2 years, but up to 35% of patients will experience a chronic disease progression. Asymptomatic elevation in liver enzymes is found in about 30% of cases, and alkaline phosphatase is more consistently elevated compared to aminotransferases. However, already in the 1980s, autopsy report showed that actually sarcoidosis of the liver can be found in up to 80% of infected patients. The clinical spectrum of hepatic sarcoidosis is shown in this table. Most of the patients are asymptomatic, but 30% of patients will have elevation of liver values, liver enzymes at the time point of presentation. Enlargement of the spleen and the liver is seen in up to 50% of patients. Clinical hepatitis is present in up to 15% of patients, and up to 10% of patients already have liver cirrhosis at the time point of presentation. And up to 20% will have portal hypertension at the time point of presentation. Only a slight minority of patients will have liver failure requiring liver transplantation at the time point of transplantation. Sarcoidosis of the liver can have many aspects, and here you can see a patient with hyperechoic nodules which are non-vascularized, and in the contrast-enhanced ultrasound you can see that the lesion is in almost isoenhancing in the late phase. To the contrary, sarcoidosis of the liver may appear as metastatic-like lesions, as shown here. You can see multiple hypoechoic lesions, and in the contrast-enhanced ultrasound, these lesions have a rim-like enhancement in the periphery and let's say a washout in the late phase. The typical histology, liver histology is shown here. Patients have granulomas surrounded by a thin cuff of lymphocytes. There's a variety of granulomatous liver disease. Most of the diseases are infections with tuberculosis in the first place, but also brucellosis and schistosomiasis may induce liver granulomas. And you have to be aware that patients with hepatitis C may have also liver granulomas. Many drugs and chemicals also induce liver granulomas, typically with eosinophilic infiltration, and also malignancies, especially lymphomas, may be associated with liver granulomas. On the histologic basis, the cholestasis in the liver has to be distinguished from patients with primary biliary cholangitis and primary sclerosing cholangitis. In sarcoidosis, usually there are many granulomas located in the periportal tract, and liver and bile duct injury is less pronounced compared to PBC, where there are only few granulomas, but bile duct injury is more pronounced. In primary sclerosing cholangitis, usually there are no granulomas. The question that arises is, do we have to treat sarcoidosis of the liver? And the answer to this question is yes, we should do, because sarcoidosis of the liver can lead to ductopenia, which consecutively leads to liver failure. There are several mechanisms of liver injury in hepatic sarcoidosis. Jaundice derives from chronic cholestasis due to bile duct injury. Cirrhosis can arise due to granuloma formation, which over hepatic fibrosis, then leads to cirrhosis. And portal hypertension can occur on a pre-sinusoidal level, but also due to portal vein thrombosis or to Bucharest syndrome. And you have to be aware that portal hypertension may arise even in the absence of liver cirrhosis. And this is the same for ascites. Independent from liver failure, ascites can arise due to peritoneal sarcoidosis. Steroids have been shown to induce little or no improvement in biochemical liver values. And corticosteroids also do not seem to prevent progression of portal hypertension and also cirrhosis. And therefore, previously, steroids have been only recommended when organ failure is imminent or organ function is imminently threatened. Ursodeoxycholic acid is a post-transcriptional secretagogue in hepatocytes and cholangiocytes and therefore stimulates hepatobiliary secretion. It has anti-apoptotic and anti-toxic activity by reducing levels of hydrophobic bile acids. It modulates the immune response by decreasing HLA-1 expression on hepatocytes and class II expression on cholangiocytes. And it has been also shown to have beneficial effects in patients with symptomatic cholestasis. A couple of years ago, a Dutch group studied the effect of UDC in patients with sarcoidosis of the liver, and they conducted a retrospective study with 17 patients comparing placebo versus prednisone versus UDC. And they found UDC to be superior in reducing aminotransferase levels, pruritus, and also, this is very interesting, fatigue of the patients. And UDC has an excellent safety profile and may also delay progression of chronic liver disease. And this usual starting dose is 13 to 50 milligrams up to 20 milligrams per kilogram body weight a day, and you should start UDC before using corticosteroids. If you have to use then steroids, the usual initial dose is 20 to 40 milligram prednisone, which is then tapered very slowly over more than 12 months to a maintenance dose less than 10 milligrams a day. And an alternative treatment option, which I find very interesting, is budesonide, and we have also experience by treating patients with this. The advantage of budesonide is that it has high hepatic concentrations due to its first-pass liver metabolism. The second line therapy in patients who have steroid failure or steroid dependence is done with azathioprine or mycophenolate mofetil. The other drugs that are listed here, including the TNF-alpha blockers, are only, have been only reported in single case reports in the literature. How should we treat advanced liver disease? It should be treated with standard medical measures. Steroids may not be any more useful in patients with advanced liver disease, and liver transplantation may be required. The reported outcome dates for patient and graft survival are comparable to other indications. And you have to be aware that sarcoidosis may recur in the graft. Thank you very much.
Thank you, Dr. Vito. That was very interesting. Questions from the floor? Yes, please. Shout.
I want to ask you about the role of liver biopsy, because in liver biopsy, in each case, or only in cases where the systemic signs of sarcoidosis are not present.
We perform liver biopsy in all patients that are presented in our clinic with sarcoidosis, with known sarcoidosis and elevated liver enzymes, because the problem lies within the fact that if they have cholestasis, they need treatment because, as I mentioned before, ductopenia may occur, and this actually leads to liver failure.
And would have also prognostic role biopsy in sarcoidosis, or only for diagnosis purposes?
It has prognostic role because it is easier actually to discuss with the patient the need for therapy, because we have patients that where UDC is not enough and we have to add steroids, and the pulmonologist always says for the lung you don't need treatment, but we as hepatologists say for the liver you need treatment.
Very nice talk. I have a question and some personal experience. We see large number of these patients. I'm Shiv Sarin from New Delhi, and do liver biopsies. You present these patients have portal hypertension and cirrhosis. In every patient we do HVPG and we do liver biopsy. Whenever the pressures are above 8 or 9, we think it is a cirrhotic who has got sarcoid, rather than sarcoidosis causing cirrhosis. How do we answer? So once the sarcoid is treated for, let's say, 1 year or 2 years, we repeat the biopsy and also the pressures. While the biopsy shows no sarcoid either in the lung or in the liver, but the pressures remain the same. So our curiosity and our thinking is that there could be 2 types, one in a non-cirrhotic liver where a sarcoid, or a pre-existing patient who has fibrosis or cirrhosis. And also the mechanisms in most patients except one who had a 17 pressure, the pressures are in the range of 10 or 12. So this is one part. The second is some of these patients have varices, grade 1 or 2 varices, as you said, portal hypertension. And these varices do not regress once the steroids have been given. So I would like your advice and comments on this.
Yeah. Thank you.
You don't want to give your feedback? There was a question because at the end.
Okay. So my comment, I understood. Okay, my comment on this is, despite steroids, and this has been shown in literature, despite steroid treatment, many patients will progress with the portal hypertension. And the point is that it seems that only UDC may have an impact on disease, or let's say may delay disease progression. In the patients who have portal hypertension, actually, in the end, if the steroids do not help anymore, I would discontinue steroid treatment, and I would treat the patients as with advanced liver disease as any other patient. Yeah.
Can I ask a question along the line? So sarcoidosis of the liver is not something which we frequently see. To better understand the pathological link to progressive liver disease, there has to be a multi-center cohort study and a multi-center effort, actually, to understand the natural history of the disease. So is it sarcoidosis that leads to progressive liver disease, or is sarcoidosis just a coincidence? Because that's what Shiv Sarin asked. Is there any effort, for example, within EASL to have such a multi-center cohort? Because that would be interesting.
Yeah, unfortunately there are no guidelines. There are only, let's say, I think there's a foundation in the US that has some sort of guidelines, but no medical community has done guidelines, I think, because the awareness of let's say sarcoidosis, and then especially regarding liver, is not as high. Although, as I mentioned in the talk, autopsy reports show that actually the involvement of the liver is much higher in sarcoidosis than thought, because only a minority of patients present liver enzymes, but still the point is it depends on what kind of damage in liver you have. If there are only granulomas, it's one thing, but if the granulomas also make a damage of the bile ducts, then actually it's worse, and also the progression of disease is worse. Yeah.
Okay, so if there are no further questions, I thank you. And this was a very interesting talk, and I would still consider to apply for EASL with a group to apply. Okay, thank you very much.